and thank you very much for joining the webinar today. We are so pleased to have Dr. Khalaf with us, and we look forward to her presentation on MDS. So without any further ado, I'll hand it over to the doctor. Thanks so much.
Good morning. Too bad I can't see your faces, but thank you for being there. It's a pleasure to be here today and give this talk, which, you know, it is sort of like basic, but I'm also happy to address any questions that you might have. I know that there were 2 questions that came through the email about probiotics and gut health in patients with MDS, and whether this would impact the overall health status of the patient, as well as if there is any risk associated. There are clinical trials as well coming down the pipeline, but I have not put in data from the trials that have not been proved to be positive with regards to the molecules that are being tested. So this is the title of my talk, and these are some disclosures. And I have to mention that I had some slides from a previous training that was offered by BMS a few years ago. So this is the Canadian and global incidence of MDS, and of course, the data are based on reporting of cases in the MDS databases. So in Canada, we do have MDS Can, which is a Canadian database that was initiated by Dr. Rena Buckstein from Sunnybrook, and she's basically the mother of MDS. I would call her the goddess of MDS, whatever. And I would encourage everyone to generously consent to being enrolled into the MDS database, because it helps us with better understanding of the disease biology and outcomes, especially if therapy or transfusions are being offered. And now with a deeper understanding of the genetic makeup of the disease and the heterogeneity of the illness itself or the condition, it helps us as well predict the outcomes and implement the precision medicine, which is basically personalized approach in management of cases. So the incidence of MDS, as you know, it's very heterogeneous. It's not anemia of unknown etiology anymore, as it was called back in the 1990s and in the early 2000s. And now we have risk scores. So the International Prognostic Scoring System, which was very simple. And now we had the International Revised IPSS, which included more cytogenetic blast percentage, in addition to age, as prognostic factors. And recently, we got the validated molecular IPSS, which includes the next generation sequencing molecular mutations, and I will address that. And I hope that everyone is familiar with the MDS Clear Path, which is a Canadian website that has been updated, and it's available online. And basically, it's good for patients, for caregivers, for physicians, whether they're hematologists or non-specialists. So it's a really good resource, and there are some data as well, and treatment pathways as well. So I encourage everyone to go on the MDS Clear Path. So based on the IPSSR and based on the data that we have, it shows you the 77% of patients are considered low risk and 23% are considered high risk. And there is another factor as well, if this is therapy-related MDS, meaning if the patient had, for instance, a breast cancer or other cancer that required certain chemotherapy, medications, or even exposure to radiation therapy, these are thought to be therapy-related MDS, and these would carry a poorer risk. And by risk, whether it's low or high, we refer to disease progression and the risk of transformation or progression to acute myeloid leukemia. Um, so demographics, so MDS, it affects more males than females. And the race, it mostly affects more all races, but it's highest in the white individuals. And here I'm not sure if this is if maybe women, maybe there are some confounders and I'm not sure. So sometimes women are actually anemic because of their menstrual cycles. So is anemia more detected in males, and hence it's more investigated or not? Also, MDS can affect all races. So is it underreported in other races? Because in the West we have better access to healthcare and enrollment in the databases. Also, the age, it's a known fact that MDS and acute leukemia have higher prevalence in older ages. Again, environmental factors and lifestyle, so exposure to benzene and chemicals or radiation or chemotherapy, which is the therapy-related MDS that I have addressed, and others such as familial history of blood cancers. There is also hereditary malignancies or germline mutations that we're now more aware of, and it's an entity on its own. So we often like or entertain the talk about clonal hematopoiesis of indeterminate potential. So we know now that, or CHIP, we call it the CHIP, and there is also the CHOP, which is clonal hematopoiesis of oncogenic potential. So there are driver mutations that arise actually in utero. So some individuals carry those mutations. And the most known ones are the DNMT3A, TET2, and ASXL1, also the JAK2, and other unknown drivers. But having those mutations would potentially carry the risk of atherosclerotic and cardiovascular disease. So patients with risk factors for adverse cardiovascular disease, such as hypertension, diabetes, high blood lipids or cholesterol, and we count obesity as well. So those are all risk factors for cardiovascular adverse health. And these also are associated with the CHIP mutations. But do other patients without driver mutations or no mutations develop MDS and AML? Absolutely, yes. And the risks are, like they cannot be pooled in one bucket. It's as I've said, and I will continue to say, this is a very heterogeneous disease. But now we know that there are other factors that might be contributing. So as I mentioned, the hematopoiesis in MDS, it could be clonal, or it could be due to other insults that happen from the environment. And then we worry that MDS would actually transform to acute myeloid leukemia or acquire worsening cytogenetic abnormalities, or would acquire genetic mutations that would render it of a higher risk and would be a life-threatening. Most people could have MDS without having any symptoms. So we could go back on the blood work for over the past 3 years and we would see a mild persistent anemia or mild persistent thrombocytopenia, meaning the red cells or the platelets are low but not causing symptoms, or even patients with lower white counts and absolute neutrophils less than 1, and they could also go without having any symptoms or recurrent infections. But these definitely would trigger a referral to hematology for further investigations, because not everyone with lower blood counts would be considered to have MDS unless we do a bone marrow to look inside and see if there are any MDS related changes or chromosomal abnormalities or genetic mutations. And of course, this is the iceberg that we know. The more we know that we don't know, unfortunately. So ongoing research is still encouraged. So symptoms associated, of course, everyone is aware of the symptoms of anemia, like shortness of breath, easy fatigue, um, um, tending to rest more. Some people might actually feel dizzy or have syncopal episodes, rapid heartbeat because the heart is beating so fast, trying to accommodate for the anemia. Of course, they would look pale. Some of them could have chest pain, and with people who have low platelet counts, they can have bleeding or bruising. And patients with low white cell count or neutrophil count, they would have fever, um, and they could have recurrent infections as well. So how do we diagnose MDS? So typically we do an initial set of blood work that would include the white cell testing for the blood counts, and we would also look at a blood smear to look at abnormal forms or abnormal shapes of the red cells, and sometimes they come in different colors. We call those anisopoikilocytosis or polychromasia. And we also look for nutritional factors such as B12 or folate deficiency. We should test for the thyroid function as well. We would take a history and see if there was exposure to heavy metals or cytotoxic therapy, whether it's chemotherapy or radiation therapy. Is there a concurrent autoimmune disease that could cause lower blood counts aside from having a bone marrow disorder, or patients with liver disease? And it's known, it's known that alcohol use and chronic liver disease could present with cytopenias and even abnormal shapes of the blood cells that could mimic MDS. But I have to mention that alcohol and tobacco smoking could have direct toxic impact on the bone marrow. And they're one of the inherited syndromes that we like to look for out of academic interest, and we are very interested in knowing if they have Fanconi syndrome. Most of the inherited myeloid disorders get diagnosed in childhood. So by the time I see the patients in their adulthood, I would have known. And then the bone marrow biopsy is a test that's done at the bedside or in clinic. And it's not really a very invasive procedure. I'm not sure how many of the attendees has been through a bone marrow biopsy or one of their loved ones has gone through that. So I hope it was not so traumatic. But we sanitize the skin and we do localized freezing similar to what the dentist does. I like to say that we're kinder than the dentist because we don't use the drill, but we take a sample from the juice, and this is tested for the blast percentage. We also stain the cells, and we send the remaining for cytogenetic and molecular testing to get more information. And we also look at the shapes of the cells, whether on the blood sample or on the terrifying biopsy, where the pathologist would slice it and then look for further for staining of the cells that could have potential malignant component, or to look for other changes such as fibrosis, which is the scarring of the bone marrow, because there is a subset of MDS that overlaps with myeloproliferative neoplasms, and they could get called as MDS MPN. And there is also the CMML that goes under the MDS realm. And I'm sure that there is a percentage of the attendees who have or have family members with aplastic anemia or hypoplastic MDS. I'm not focusing too much on that, but I'm happy to answer questions. So as I mentioned, genetic testing is very important. 50% have de novo MDS. 50% of patients with de novo MDS would have more than one cytogenetic abnormality. And there are cytogenetic or chromosomal abnormalities that would carry good risks, such as the del5q. Some others would have normal risk, and others would carry poor prognosis, especially if they're multiple. So this is a pie chart showing the most common cytogenetic abnormalities. So deletion Y chromosome is very common, and it could get acquired in most elderly male patients. And it's actually good, of good prognosis. Sorry, it's 40%, and 40%, 48% of the cases would have normal cytogenetics, which is good prognosis. Deletion 5q, 3%, and it's also good. Sorry, deletion 5q is 14%, and deletion 20 is 3%. It's also good. Trisomy 8%, and it's intermediate risk. If you have a monosomy 7 or deletion 7q, this is a poor risk on its own. And then complex or more than 3, those are 14%, and they carry very poor risk. Some of the mutations that are associated, but of course we have more. So SF3B1 is associated with the ring sideroblast, and this is a good risk MDS. Others, the TET2, the ASXL1, and the DNMT3A are very common in patients with the CHIP. TET2 is also associated with the CMML. TP53, commonly associated with very poor survival, and we see it often in patients with complex cytogenetics, meaning more than 3. And SRSF2 or ASXL1 on its own, these are associated with adverse risk, and the RONX1 as well, and this could be associated with thrombocytopenia, and it could be familial. So as I mentioned before, the prognostic scoring systems, we had the IPSS and the IPSSR, and it's a calculator that you would be able to punch in data and get the scores. So as here as well, I mentioned the MDS clear path that you can basically access online, and it incorporates the IPSS mole at the same time, or the molecular. And then this is the overall survival based on the scoring system of the revised IPSS in patients with MDS above the age of 60 and less the age of 60. So as you can see, mostly patients with a very low risk and low risk MDS have a higher percentage in younger than 60, and the survival, overall survival, is better in patients younger than 60. However, it's lower in patients older than 60. This could be related to the accumulation of clonal hematopoiesis, a genetic component, or cytogenetic abnormalities, or other risk factors associated with inflammatory conditions that affect the body in general. And as we age, the bone marrow is another organ that could also get impacted by age and inflammatory changes. Same thing with the heart or the kidneys. So we're made to not last long, unfortunately, but we try to improve the quality of life and improve the outcomes as much as we can. So the IPSS-M model, which incorporates the genetic mutations, this is also found now on the MDS ClearPath website. And you can basically punch in the bone marrow percentage, the platelet count, hemoglobin, and the cytogenetic abnormalities. So the blood counts, we try to punch in the blood counts that were seen at the time of diagnosis of MDS. The subset of, does anyone have questions now?
The attendees can't they don't have the ability to ask questions out loud, but if anybody does have questions and they want to put them in the chat, I can then relay them to Dr. Khalaf.
Okay. So the category of MDS MPN is an overlap syndrome, and so the CMML is one of them, and we could also see MDS MPN unclassified. So the commonest one is the CMML, and we see this, it comes in two forms. So some of those could be with cytopenias, meaning the patient would present with persistent elevation in the monocytes, which is one of the when you look at the CBC, you would find the total white count, the neutrophils, lymphocytes, monocytes, basophils, and eosinophils. So these are all stages in the maturation of the white cells, and the monocytes, which is a subset of the white cells, could have persistent elevation for over 3 months above 1.5. And there are certain changes that we see in the bone marrow, and certain criteria as per the WHO for classification as well.
Dr. Khalaf, can I just interject? We do have one question. So before we get too far along, the question is, where does DEL13 fit into these genetic mutations?
So deletion 13 is considered one, I believe, of the poor prognosis or inversion 13. So 13 and 3 mutations are not associated with good prognosis, but I can also verify that. I don't know if you want me to answer that now, or should I maybe address it after?
You can address it after if you like, whatever works.
Okay. Can you still see my presentation?
Yeah, it's right there.
Okay, good. So other rare conditions are the atypical CML, where BCR-ABL is negative, but the patient would fulfill criteria for CML, or the juvenile myelomonocytic leukemia, similar to the CMML, but it occurs earlier in childhood, and the MDS MPN with ring sideroblasts that are proliferative as well. So they have the ring sideroblasts, meaning iron stained. The blasts are iron stained, and they have those stippling around the blast cell, and they could come with thrombocytosis, meaning their platelet count would be also elevated. Yeah, so these are the ring sideroblasts, as I mentioned, in MDS, and it's associated with RSF, the SRSF2 mutation, which is, the SF3B1 mutation is associated with good risk. So this is a good risk entity. This is an algorithm, a simple algorithm for approaching management of MDS. So if patients come with lower risk, at any age, we could start with iron chelation if they're transfusion dependent with iron overload. We could give them growth factors, such as the grastafil to promote the growth of the white cells, erythropoietin stimulating agents like eprix and darbepoetin, and recently we have the luspatercept. Rarely do we use the hypomethylating agents in this category unless the disease is behaving like a higher risk with worsening cytopenias and transfusion dependence. Lenalidomide or Revlimid is also used in the DEL5Q. And immunomodulation in clinical trials. So there are multiple studies coming down the pipeline. Not a lot of them have been confirmed to be positive. If the patient progresses to a higher risk, or if they're presenting with higher risk, a transplant would be ideal, especially if the age is less than 75. Of course, the higher the age, the transplant associated mortality would go higher. Higher risk individuals, we typically start them with a treatment with a hypomethylating agent, with or without venetoclax, which is a BCL2 inhibitor, and I will go into more details about that. Sometimes if they present with, recently the ALN guidelines, since the last spring and summer, have recategorized. There is a category of MDS AML if the blood percentage is between 11 to 20%, and if the patients have other co-mutations such as NPM1, which is considered a good risk mutation in AML, but in MDS it's considered as poor risk. So sometimes we do take those patients to induction chemotherapy, which is similar to how we treat acute myeloid leukemia. Excuse me. So again, the treatment options are based on the risk score, the age, and the patient's performance status, and of course the patient's wishes and their philosophy of care. So hypomethylating agents, which is azacitidine and D-cytobin. Recently, we have the oral D-cytobin, which is the Inqovi. Immunosuppressive therapies for patients with hypoplastic MDS or aplastic anemia. Sometimes we give the hematopoietic growth factors or erythropoietin stimulating agents, or even the luspatercept, which is a ligand trapper. And the hypomethylating agent with a BCL2 inhibitor for the MDS AML category, or immunomodulation. And of course, everything is somehow tied by funding. Some medications are acquired compassionately, and some are through clinical trials. So as mentioned, that the cure would be through going through transplant, but again, transplant is not for everyone, as it might not be associated with good outcomes in terms of survival due to toxicity. That's why we prefer to assess the patient as a whole and not just as like MDS diagnosis, because there are other factors that we'd like to take into consideration when we're addressing transplant or not. So since low risk MDS comprises a big percentage of the patients that we see, so we like to optimize supportive care. So as mentioned, growth factors like Grasfil would be very helpful, or even Neulasta. Or if the patient is anemic and starting to require transfusions, we like to give erythropoietin stimulating agents or luspatercept, especially for patients with a refractory anemia with ring sideroblast. Luspatercept works great. And for patients with transfusion associated iron overload, iron chelation is always encouraged to prevent the sequels of iron overload and multi-organ involvement. Patients with del(5q), we could try the lenalidomide, which is easily accessible. And then if patients come with asymptomatic anemia, they have low risk disease and their counts are stable. So we just do a watchful waiting kind of approach. If they're non-del(5q), we can enroll in a clinical trial. Something like luspatercept was actually started as a clinical trial, or patients on azacitidine or D-cytobin, or the combination of D-cytobin and cedazuridine, which is what we're using now in the market name of Inqovi. If the patient's counts do not show adequate, oh, there is a question. Is Vidaza available? Yeah. So the Vidaza is available in a pill form, but it has not been studied in MDS yet. So it's available and confirmed to be beneficial for patients with AML and with certain criteria. as a maintenance therapy. Um, and it's deemed to be as efficient, but only in the AML category. So it would not be used in patients with MDS. So what has been used and studied is the INCOVI based on the ascertain trial. Does this answer the question? Do you have any other questions about oral Vitasa? Can you guys hear me?
Yeah, they can hear you. She said no thanks. So it'll be in the chat if people have questions.
Okay. All right, thank you. So if patients have inadequate response to supportive therapy, or if there is concern about disease progression, I always like to perform a bone marrow just to see what's going on. Is there a progression in the blast percentage? Is there a newer genetic abnormality that has been acquired? Or maybe something else is happening in the counts are low. Someone has a gastrointestinal bleeding or something. So as you see, we can switch between medications. If the patient is on lenalidomide in a del5Q, we can add ESA. If they have, they're on ESA, we can add lenalidomide. If they're on ESA but they cannot get lenalidomide because they don't have the del5Q, we can try immunosuppressive therapy or HMA, or optimized supportive care. So as you see, like, we have some options to use. And then if there is if progression to high risk MDS, if this patient is eligible for transplant, am I giving them induction chemotherapy or not? If they're not eligible for transplant, so I should consider hypomethylating agent with or without the venated plaques, which is the BCL, with the BCL2 inhibitor. So treatment options, as I mentioned, the stem cell transplant, hypomethylating agents with or without the BCL2 inhibitor. And sorry, that's not an equal, it should be a plus. Or cytoreductive therapy if they have a proliferative CMML. So we could try hydroxyurea. And then, as I mentioned, I always like to ask at the beginning, ask myself if this patient is eligible for transplant or not eligible for transplant, because that would sort of stratify this. Help me with the strategies that I'm going to pursue, and of course, the patient's autonomy is very important. So erythropoietin stimulating agents for the serum erythropoietin level less than 500, we could use Eprix or darbepoetin. These are not encouraged in patients with higher risk MDS because there is a concern about progression of the blast percentage, and patients with a ring sideroblast more than 15%, we're encouraged to use the Grastafil, which is the white cell growth factor. Again, we like to see a response with erythropoietin stimulating agents, but there is no adequate response. We could always go up on the doses and then further assess. If not, we can use luspatercept if they're low risk or with ring sideroblasts. Of course, survival is impacted. Survival and quality of life are both impacted by transfusions. So more than so these are the overall survival in patients with 0, 1, 2, or 3, or 4 units of packed red blood cells. And as you see, if for 4 weeks, and as you see, those who have more transfusions would have worsening outcomes and worse survival. In patients with no transfusions versus low transfusion dose and high transfusion dose, with a survival over years as well, of a progression-free survival. Because iron overload comes with inflammation, and inflammation could potentially worsen changes in the bone marrow environment and in the body, like all the organs altogether. And of course, patients with transfusion associated iron overload are encouraged to start on chelating therapy, especially in lower and intermediate risk MDS, but not on high risk or acute myeloid leukemia. So we have two types of iron chelators. One of them is injectable and one of them is oral. And the oral one is basically approved for patients with lower neutrophil count because of risk of infections. So we have some Canadian recommendations for iron chelation therapy, and I believe that there was a talk by Dr. Heather Leach from BC, and she's the most knowledgeable person on iron metabolism and iron overload. She's quite passionate. If you want to know more, you can access her talk and her slides on the website. Of course, as I mentioned, there are benefits from chelation of the iron therapy. Sorry, iron chelation therapy. Do you mind if I just get a glass of water? I apologize about that. So the event-free survival of patients who have received iron chelation have significantly improved, and we've seen remarkable longevity versus those who are receiving placebo. Now, I mentioned luspatercept or rablozyl, and this is an injection that's taken every 3 weeks. So it's a ligand trapper, as we like to see it, and it stimulates erythropoiesis, or the formation and the maturation of the red cells at a later stage. So the earlier stages are erythropoietin dependent or EPO dependent. In the late stage, luspatercept does this ligand trapping, and it enhances erythropoiesis. So that's the medalist trial that was studied, and it included patients with low to intermediate risk MDS. Del5Q was excluded. From a real world experience, it does not work for patients with CMML or proliferative MDS MPN, especially if they're on hydroxyurea or other leukoreductive treatments. The outcomes of the study were quite positive and encouraging. It's a very well tolerated drug. And as you see, the response is significantly higher on luspatercept compared to placebo in the same in comparative populations. And as you see that there has been significant transfusion independence over time. And this is the hemoglobin response. Now, there was a study that was shared at ASH of 2022, looking at the use of lenalidomide versus placebo in patients with low risk deletion 5q MDS patients. Basically, after 12 weeks and 6 months, patients who were on lenalidomide and they're not acquiring any significant outcomes, they would stop the drug. And they were looking at transfusion dependence or not. So this is still in progress. I just wanted to mention that there was an article on McLean's with one of my patients. He has generously shared his story, and then you can also always access this. I believe it came out on October the 25th, which is the MDS International Day. So I can stop sharing the screen now, and I welcome questions.
So please just put your questions in the chat, and the doctor will be able to see them and respond.
Too bad that I can't see faces.
Are there any further questions from anybody?
Yep, if chemotherapy doesn't work, does one go to immunotherapy? So that's a very good question. So immunotherapy is basically used in patients with, considered if patient comes with hypoplastic MDS or aplastic anemia. If chemotherapy does not work, and immunotherapy is not indicated, I would not use it, because anything that we use could come with side effects. But we could try newer drugs or newer molecules if there is a clinical trial. So we always try to invite patients to consider clinical trials. So there are multiple centers here that have clinical trials. So whether it's PMH or Sunnybrook or our centers, so these are the three main centers, and there are other satellite centers as well that have hematologists who are specialized in MDS management. And if a clinical trial is available in Toronto, I would, and my patient lives in Hamilton, I would still encourage them to, get some information and consider that. We didn't talk about Ravolade, which is, we spoke about erythropoietin stimulating agents for red cells. We spoke about the growth factors or grastofol for the white cells, but there's also Ravolade, which is used in aplastic anemia or immune-mediated thrombocytopenia. So this is something that we can always try to access, and we have been getting luck as well.
Are there any other questions today? Okay, I don't see any, so I just want to take this opportunity to oh, I think we have another one here.
Hypoplastic MDS and PNH had ATG coming off cyclosporin, incidence of needing more treatment. Yeah, so we always like to monitor the PNH clone because sometimes it expands. And honestly, all the patients with hypoplastic MDS and a small PNH clone, they could stay off therapy. I have not seen a patient with hypoplastic MDS who required therapy in the future, provided that there are no other contributing factors. But we always need to watch the PNH clone with serial flow from the blood. So good luck staying off treatment.
Any other questions? Oh, we do have another one.
Is there? Oh, yeah.
Oh, just thanks very much. Okay, great.
Good luck.
Well, if there are no other questions, I'd like to thank you once again for sharing your expertise with us. And I want to thank all of the attendees for joining us today. Our newsletter went out yesterday, and we are going to be having in-person meetings, which we're excited about in the spring. So please continue to check our website, and you will see any upcoming meetings and or webinars in the future. So thanks once again, everybody, and have a good day. Goodbye.
Thank you for inviting me.
Bye.